it needs to be emphasized that HIV is basically one of those conditions that you can do quote unquote all of the right things and still get it. Not because it's a bad person's disease, it's because once you have intercourse, anyone is at risk. And many times even the persons who you may acquire it from may not be aware of their position themselves. HIV is real. It has been around for some time and probably will be with us for a little longer as well. What we can tell you is, because we have gained so much knowledge over the years, HIV is not killing persons anymore. One of the problems that we have now is this whole thing called stigma and discrimination. We cannot afford to be looking down on people or to be gossiping about it. If somebody has acquired something, yes, you be empathetic, be happy that it's not you. But then that person also needs support. Support does not mean that you talk about it. We need to work on this. It's not just a Jamaican problem. I should say it's a global problem, as a matter of fact. Discrimination, it's a very bad thing. And we need to get HIV down to this point where you can be on a bus and you say, you know, I'm HIV positive. It's the same that you can say I had a flu or a cold or something, and then nobody comes down on you like that, because it can affect anyone at any time. Good people, bad people, if there is such a thing as bad persons. So we encourage you to get on board and be sensible about it.
In Office with Dr. Jevon Samuels.
Welcome to another episode of In Office. I am Dr. Jevon Samuels. In Office is a program which we talk about life, sickness, and death, and it's a very good podcast for informative medical content. Today in Office, I have a special guest here. His name is Patrick Challenger. Welcome to the show, Richard.
Good evening, everybody.
Okay. All right. So my guest here today is a resident in infectious disease, and he's basically managing several HIV positive patients over the years, and today we would like to discuss the management of HIV positive patients. I'm not going to do any lengthy introduction this year where that is concerned, because he is the guest here specialized in the management of these patients, so he would be fully aware of all the different aspects of management and the pathology that involve in this disease. Now, Dr. Challenger, HIV. What is HIV? HIV/AIDS.
All right. Good day again, everybody. HIV basically is an abbreviation for human immunovirus, really. It's one of those viruses that have been around for several years that became a little more popular in the 80s when we found out about it. Generally, it is sexually transmitted, but it can be transmitted from, let us say, a mother to her child during pregnancy or during birth, or you could get it through blood transfusion. And unfortunately, because of stigma and throughout the years, it has become basically affiliated with practices or lifestyles that we deem not so particularly noble in our society.
Okay. Now, you have mentioned a few means in which it is transmitted, but I know that in terms of transmission, you have a high prevalence in in homosexual males, right?
Yes.
And yes, and also persons heterosexual. I think overall is the largest group of persons that is transmitted via. But in terms of the percentage from a particular group, men who have sex with men tend to have a higher transmission. All right. So other areas of transmission also include, as I said before, the mother-to-child transmission. Some persons with IV needles, some via blood transfusion at hospital. But in our setting here in Jamaica, what's the most common means of transmission, and what are we doing to address these?
All right. So in our setting, there still remains that high percentage of persons, as you have mentioned, in the MSM. That's a population of men who have intercourse with men. You also find quite a bit of it in commercial sex workers. That's persons who, for whatever reason, may have sexual intercourse for reasons sometimes to support their family, not necessarily a negative thing there. Sometimes persons just feel like it's their only recourse. We also do have accidental acquisition. It's very low, but it is a real factor, more so amongst healthcare workers who may get an accidental stick or two. But generally though, rather than categorizing it in terms of who gets most of what, it needs to be emphasized that HIV is basically one of those conditions that you can do quote unquote all of the right things and still get it. Not because it's a bad person's disease, it's because once you have intercourse, anyone is at risk. And many times even the persons who you may acquire it from may not be aware of their position themselves.
Okay. Now, in terms of the talk about like symptoms, like we normally know we have high risk groups and for transmission of HIV/AIDS, but in terms of symptoms, how do normally persons with, apart from the screening test that may be done on an asymptomatic person and will pick up the HIV virus, what are some of the symptoms that sometimes persons present with, which you may think that, oh, we should test this person, or it's a high chance that they may have HIV?
Okay. All right, so the symptoms vary, but first, before I get into the symptoms, you have already said that there are times, yes, when we can pick up on a person, just maybe from just a little routine screening. You may be going somewhere, you see a van or somewhere somebody encourages you to do an HIV test, and then many times you may pick up on it and the person is quite healthy. That healthy position, or what we call asymptomatic, represents a lot of persons out there. So if you're thinking that HIV must have certain sort of things that you look for, that would be one of your main mistakes. Okay? When the symptoms that we do see is quite varied. Simply, at times it could be just a thrush, little white little plaques that you see in the mouth, on the tongue, in the back of the throat, little skin lesions. Sometimes people think that it's like they were bitten by a mosquito and then they had this little reaction. It may heal, but then it just remains hyperpigmented or these little darkened spots. And you tend to find quite a bit of them on the extremities, on the feet, and so on there. There are other little things that we may find become a little more stuff, like a little more common, like night fevers. These little it's basically called HSV infection. Comes at the corner of the mouth. Sometimes chicken pox, shingles, I think, is a better example. At the extreme end of it, one may find that they are losing weight despite eating normal. They may have several things. You present with anemia, you present with kidney failure, headaches, dizziness, sometimes just seizures, but those are at the extreme end. But as I said, it is quite important that HIV is, as a physician, generally we don't look at patients and say, okay, that's a person who has HIV. But when we do pick up certain things, though, we tend to realize that this is more of an advanced stage, because we also have what is known as AIDS-defined illnesses. So that's the point that we'd just like to make. There's no particular one set of symptoms.
Okay. Now, you mentioned AIDS-defining symptoms, right? But for example, if someone did not do any screening, we didn't identify HIV in them, what's the time frame we're looking at before they normally develop these AIDS-defining symptoms?
All right, so you can have HIV for years without having any symptoms, right? And it really varies as to why two persons, one, they would have contracted the condition at one particular time, and then you find one person may go up to 10 years without getting any symptoms, and then another one, like about 6 months to a year, may start to present with different symptoms. It all depends on your health, your diet, your lifestyle, sometimes your genetic makeup, how old you are at particular times, in terms of when. But the answer to that question basically is it varies.
Okay.
So you may pick up on a person may present to the hospital, let us say, with seizures or fits, and then you tell them that you test them and you find out that they're positive, and they're thinking, but I'm not even active, not realizing that it may not necessarily have been something that you did recently, but sometimes as much as even 10 years or stuff before you would have acquired that.
Okay.
And only only when they look back, they would have realized that, hey, I have not been tested since that particular time, which is what we're saying. There's a period of being asymptomatic that is one of the reasons why this condition is still around. Because if we had set symptoms, then persons would have been able to put measures in place to try and even prevent it. But quite a few persons out there are asymptomatic.
Okay. Now, in terms of viruses, normally persons will get like the flu virus or other viruses that's called gastroenteritis, and your body will just clear these viruses. What's the real reason why HIV virus is so detrimental to the body and have difficulty? We are unable to cure it, we only can control it. What's the issue? Or how does these viruses work? But state it in simple terms so the average person in the street can understand. I know it will get very complex. But
all right, so unfortunately, the HIV virus is not one of those types of viruses where you would have contracted it and your body gets it under control and then it goes and then you can't get it. HIV virus basically is a master of deception. So what you find is that whereas you may get your primary infection, symptoms may come initially, then you get back normal. But then the virus has this ability to still stay within the body, sometimes in the lymph nodes. All right, lymph nodes are what we would commonly know in Caribbean as wax and cannon. They're just little areas in the body, not just always within the groin, but you have it deep inside the body as well, where the virus is able to stay there many times without causing any problems, and then over time it can make a resurgence. Not just HIV, the herpes virus and the family of those type of viruses as well are able to do that. The problem with HIV, though, is that sooner or later it does tend to come back, and it comes back with a vengeance. And that is when it causes its major problems.
all right, let's go further into details in terms of management. So what are some of the tests that you guys normally do too? So if a person is diagnosed with HIV, confirmed, there are some of the blood tests or imaging or whatever you get that you guys normally do, the part of the management of these patients.
All right, so diagnosing HIV or testing persons is fairly simple. The antibody testing is basically what is done now. A few years ago, it had to be via blood, but now you have more simple procedures. You don't have to get a needle stick. There are procedures where you can even buy there are even little commercial kits that you can buy at your pharmacy, and then you can swab the inside of the mouth. You have those that finger prick can be, or your conventional test that you go to basically a lab or to your doctor, and then they will do that, and then you can get your results in just a few minutes. So it's fairly simple. But what we'd like to tell persons though is that you shouldn't sit back until you think something is going on. Once you're having sexual intercourse, and especially if you may not necessarily be in a monogamous relationship, and then your partner is also monogamous. These are things that is always there. It's not for a particular type of person. You're always at risk, and so you should be tested regularly.
Okay.
And it's a simple test, as I said. You don't have to go out there. You can buy your test and you get it, and you can get your results within the privacy of your home.
All right. I want to in terms of testing, after you confirm that someone has HIV, all right? Talking about the management in terms of following up with the patient, like normally it takes like the viral load or the CD4. Why do you guys do these tests? And
all right, so there is we'll look at that a little later. There is management in terms of HIV. All right, how do we know what the disease is doing? You can be asymptomatic, as we have said. Asymptomatic means that you are quite normal, nothing is happening to you. However, things can be going on. One of the mistakes that was being made in the past is that we would basically look at persons, and when we saw that they were becoming ill, then we said, something needs to be done. Now you don't have to guess. The CD4 count, which is basically a specific special cell group of white cells that you have in your body that the virus targets. The virus loves those cells. If you have a lot of virus in the body or your viral load is high, your CD4 count tends to fall because they multiply within these or they divide within these white blood cells, and so they tend to fall. So the labs that you go to have special tests where they can actually monitor. Your normal CD4 count should be somewhere like around 400, sometimes to 1500 in terms of count. HIV tends to drop it. If we tell you that you have AIDS, your CD4 count would have gone to less than 200. 200 is just that number where your body's ability to fight, and your white cell count is like your soldiers. All right, they try to keep order, they keep infections, they keep cancers and stuff on board checked. So if you get to less than 200, then we say that you're AIDS, meaning you're severely immunocompromised, right? Viral load now, yes, that's another test where we can actually monitor the amount of blood, the amount of virus that you have in your body. We tend to use these two tests, the CD4 and the viral load, to see how well your medication is working. Okay. Because if we're checking your CD4 count and it is still low and your viral load is always high, it means several things. Most times it means that your medications are not being taken the way you're supposed to take them, or it could mean that the medication may need to be adjusted, or it's just not working. So this is two regular tests that we do quite often. Okay. It's not a test that you can do on your own. It has to be done by your healthcare provider.
Okay, so apart from the CD4 and viral load, do we normally do additional blood tests for these patients similar to like chronic illness?
All right, so HIV is a chronic condition, right? And what we need to realize is it's affects other things. So if you're diagnosed with HIV, we would check on your kidneys, we would check on your liver, we check on your cholesterol, we check on your sugars. We tend to do basically our routine tests as well. One of the reasons that we do that, yes, the medications that we give you known as antiretroviral therapy, sometimes they may have a little bit of a side effect. It is not the usual case. It may have a side effect, and so we can monitor your liver function and your kidney function. So if we see these things occurring, we will know, hey, we need to stop, we need to adjust the dosage, we need to give you a different set of medications, right? And so we do this periodically. We tend to do it maybe once or twice a year in every person, so that you're not just being put on these things and we're not monitoring what is occurring. But we tend to check. We tend to get a full internal organ assessment as far as these blood tests are concerned. We also check the urine as well. Sometimes we do the hormonal panels as well.
Okay. All right. Now, if when you say a person have AIDS-defining symptoms, you want to expound on some of these symptoms or illnesses like opportunistic infections that some of these patients normally develop, and what are the chances of someone recovering from these infections?
All right. So, Dr. Summers, we mentioned previously about the CD4 count, right? The CD4, as we said, they are the body's policemen. They know how to keep us in check. Now, if your white cell count become generally, even as it's not something that's under our control. If you have enough if you have your white cell count or your CD4 count is at an acceptable level, you're generally protected. So there are lots of infections that we could be succumbed to. A whole lot of fungal infection, a whole lot of viral and bacterial infections. But because your CD4 count is within a nice normal range and they're functioning well, you are protected even if you do not know. So many times you may go to your physician and with a particular condition, and then the physician will say, I think you need to do an HIV test, and you're thinking that they're judging you. It's not that they're judging you. AIDS-defining conditions are things that we know today that if we see it, more likely than not, that person is immunocompromised. So this is immunocompromised, it could be from HIV or something. So these may be simple things, and I've mentioned a few of them, just like the oral candidiasis or the thrush that we see. Certain things in women as well, recurrent urinary tract infections or vaginal infections into skin, losing weight, certain types of cancers. These are things that are basically known as age-defining, right? So once you see those, we can do that. Question is, can we come around? Yes. If you are diagnosed with one of these AIDS-defining conditions, you need to be on treatment. Right? Once you get on treatment, many of these conditions can then be reversed after your body has fully recovered. Right? Many, not all, but most of the times you can recover, and that chance of that same condition coming back is then significantly lessened.
All right. Now, in terms of management, in terms of the different groups of healthcare workers that assist with the management of HIV/AIDS, I know that in terms of when we learn about the management of illness in school, like about the biopsychosocial model, I think when I really checked on different conditions here in Jamaica, I think that one of the illness that the biopsychosocial model really works well is with the management of HIV patients. So I want to discuss to the viewers, some persons may be listening who have HIV or AIDS, and may want to know who are the different team members that normally manage these patients.
Okay, so that is in essence what I do. I am part of a team. I work in the government system. Now, HIV, unfortunately, it's not considered in our society as another chronic condition. That is where we are hoping that we can get to. But there's this whole stigma. So, for example, if you're told that you're positive, rather than you being concerned about yourself and your health or whatever, a whole lot of things tend to overtake this person. What will my spouse, what will my siblings, what will my friends, my co-workers think about me? And so you find that many persons have different coping abilities. Depression comes into play, suicidal ideation, some persons just plain give up. In the system that we have in place in Jamaica, the different hospitals and certain specialized centers, we have a multidisciplinary team of persons. So the doctor's point of view, like myself really, is to try and introduce you to the medications, introduce you to the compliance that is needed, what the medications are expected to do, and how you will benefit from that. But persons have different needs as well. If since your diagnosis you're not sleeping well, you just don't know what to do, it may mean that you may need a little bit of counseling, or you may need to talk to someone. In most systems, we have counselors on hand. Right? Let us say you would love to take your medication, but sometimes you don't even know where the meal is to come from, because let's face it, sometimes yes, the medications are better tolerated if you have a meal. So let us say you would love to take your medication, you're hungry, you just don't have the finances. Most places we have people on board who can assist you along that line. Your clinic may not be in proximity or close to where you live. You come. And then you have means and bus, so you can get your bus fare to go there. The team is as such, if they don't see you coming for your regular follow-up or whatever, you get a friendly call. You can't get out of your neighborhood, the roads may be blocked, it's a volatile area, and you're wondering how you can get your medications. We have ways of getting your medications. You say anything that occurs with you, and at least from where I work, if we have specific clinic days, but if you have any condition, any matter at all, we have one out of two things. You may be given some of our contact investigators or adherence counselors personal numbers. So you can message them or you can call them and you can ask about whatever may be happening. And then they will, it's always confidential, it's professionally done. Nobody, everything is just kept private. They can give you some advice online, or they will tell you can come in and see the doctor. So whether or not you have an appointment, we always make sure you have special, you get catered especially for. In most clinics as well, we try and do everything so that you don't have to be going from here to there. Because let's face it, yes, many persons are not going to offer because they still think that there's something wrong with it. And that's what we don't want. We don't want persons to get caught up with all of the fears and the concern to the point where they neglect their health. So that is the approach that we have. So it's not just a one-time thing. And everyone who you may come in contact with, they're all professionals. They have to, they operate under a code of etiquette that they have to confidential. They just have to operate under that, right? And we speak to you with respect. We expect you to also interact with us. We can't help you unless you even tell us what is happening. Sometimes we even speak with family members as well. Sometimes you can ask somebody to come in if you're having some difficulty, and we can do that for you. And it's not just a little one-time thing. Most of the centers that we have around the island are catered with these special facilities there.
All right. So, Dr. Challenge, I know that you manage several patients with HIV/AIDS over the years, right? And we have seen that some patients, they do very well. Some persons don't do very well, right? Some persons open up with their diagnosis with family members or close friends. Some persons keep it a secret from everyone else, right? So, based on the different groups of patients, what are some of the lifestyle and characteristics of persons that normally do well? What do you find out about these patients in terms of whether they are open to family members, etc.?
All right. So, unfortunately, or fortunately, depending on what you're looking at, many persons at times tend to think that once they're diagnosed with this condition, that they have to tell someone. That would be the ideal thing.
Yeah.
We have unfortunately seen many cases where persons have gone to a parent or to a sibling, and because those persons themselves who may need to even speak with somebody have dealt with it in a far from appropriate manner.
Okay.
Where they may distance these people, say things about them, and then may even go out and tell other persons, right?
Okay.
And that is a real thing. And so many persons have opted just to keep it to themselves, right? We usually encourage, because there may be times where you may need to speak to someone even just for therapeutic reasons or whatever. We encourage that. But if you think that you have that power within yourself to just keep it to yourself, you do that. However, we do let them know that you have a moral obligation and decency that if you're having intercourse with someone, that person need to know, and you let that person decide, right? There's no way out about that. You keep your status to yourself because that is what you consider best. But remember, if you're going to have sex with someone, you're going to be putting them at risk, and so you should tell that person this is what is happening. You're either going to use a barrier method, or if you're going to go without any form of protection, you must tell that person and let them decide. All right? And there's several benefits as we can look into as well in terms of even when you're taking your medications as well. So we always encourage, but we cannot force you to do that. Sometimes the patient themselves would know when would be the best time or who would be the right person to disclose their status to.
Okay. All right. Now, in terms of the educating the entire population about stigma associated with HIV, and it's no longer a death sentence. One, And two,
That's quite true.
It's not a death sentence in modern time. And two, it have to be transmitted via sexual activity or blood transfusion or other close contact, right? So it's not transmitted via droplets or contact with just touching or using utensils that others use, right? But why is it so hard for like the entire population, even with the current advert promotion against HIV stigma, why we still have such a high level of stigma to these patients?
That unfortunately is the problem, and I mean we're always looking into that. That's why still the media we're trying. If you will hear quite a few things. Even yesterday, I saw it written on the bus. A passenger with HIV is a passenger, right? People may probably just look at it, right? But a statement like that came out because there are persons who may not want to even sit near to you or talk to you because they're thinking they're having about what as we've said, the population need to understand, and what we need to do, we need to keep people in check as well. Even if it's idle chatter, there's certain things that are just not fun. If you know somebody is positive and then another person is saying something, or you need to say, yo, this is not the right thing, right? That person could be you. Yes, it can be you. You can be that husband or that wife who is there, and then HIV comes home to you, right? You've done all of the right things, all right? So we need to understand that these persons, the diagnosis itself, which it should not, plays on their minds, right? We've had persons who come to the hospital and they are so sick, and even just a little bit of support from family members would help a lot. But because they're in the hospital, they're thinking that if our family members come, maybe somebody might tell them. No, that is not the case, right? We cannot tell anyone about your state without your permission, all right? But sometimes the people would just like to even know a family member would come, visit them, bring some flowers, bring some fruits or something in the hospital, but they're afraid of this whole stigma. So what we're trying to do now, we are working on it in terms of public awareness. We're trying to let everyone just accept HIV as a condition that anybody can get. And we're also trying to let people know you need to be tested. And once you get that diagnosis, the only thing that is different now is that you have to be on regular medications and regular follow-up. Importantly, once we get you to be virally suppressed or undetectable, there's so much things you can benefit from. So much things. If it is your desire to have a child, you can have a child who is not HIV positive. Right? It's just a matter of bringing in your partner as well. Your partner could be negative if you are undetectable. The convention is if you're undetectable, there's no virus basically in your secretions for you to pass on. Right? So you have that discussion with your family, with your partner. If they want to go on PrEP as well, that's another thing we can speak about, Dr. Savas, the whole PrEP and PEP, then they can do that. Right? So we are working on it on the whole community education, but we still have a lot way to go. We still have a far way to go.
All right, so I guess I wanted to move into the medications that we use to treat HIV, but I guess we can just talk about the PrEP right now. So if you want to go ahead and expound on what exactly does that mean?
All right, so PrEP essentially is HIV medications that we basically for right now in the system, it is being promoted for high risk persons. A persons with multiple sexual partners, and we've targeted many members from the MSM group that are there. Essentially, you're being placed on medications. First, you must be tested that you are negative. Once you're negative, you're placed on medications, right? You have regular medications that you take 1 tablet per day. After about 7 days, that's the convention. Then the chances of you transmitting HIV from someone or contracting it is almost negative. There's also preparations where you double the dose on one particular day, and then like 3 hours or so after you can have intercourse, and then you keep on taking the medication just for about a week, and then that's it. They're different preparations as far as prep is concerned. If you do have let's just say you have an encounter, or God forbid, let us say perhaps it was not consensual or whatever, then there's also PEP, right? Which is post-exposure prophylaxis that you can put on. And basically, you're placed on HIV treatment for about 28 days, for about a month after that exposure, as soon as possible. I think you have maybe out to about 72 hours after that would have happened. Let us say something occurred today, almost like emergency contraception.
Yes.
Then you put yourself, you're placed on a 28-day regimen. You're tested first, yes, and then after that. All right, so there are different ways of treating it. The regimen that we use in terms of PrEP is different from PEP as well. Okay, so there are ways around it to keep it under control.
Okay, so for those who are listening, how do we obtain these medications? Do we have to get a prescription, or we can just go and buy them at the
All right, yes. No, you cannot get these medications over the counter like that, right? Because you have to be educated, right? Because even though these things are effective, you will always read that the effectiveness of some of these things. You're not going to see it given as 100% that you can take this, you can never. Because you have to be informed what's the proper way to do these things. So no, a doctor has to be on board. You have to be tested. They have to advise you how these things need to be taken. You have to get checked from time to time to make sure that they're being effective as well. Right, and especially even with the HIV medications as well. When we're putting you on these medications, we know what they should do. But if you have 3 different persons who are HIV positive, and we put them on the same medications, depending on their makeup, the genetics, we may get the effect on patient 1, we may get the effect on patient 2, and we may get a little immediate thing. Patient 1 may reach to a level of suppression within 6 months' time. Patient 2 may be lingering, different things. So what you find, every patient is individualized. So we would have to see them in our clinic from time to time. And then we will monitor your CD4 counts and your viral load count. And then we can tell you what is happening. And this is something that we do from time to time. It sounds a little complicated, but with time, we tend to find out what works for patient A, what works for patient B. So once we've had you for a little time and we see something that's deviating from the norm, then we can say we may need to shift focus, or we may even need to speak with you. And what I can tell you, Dr. Samuels, is the medications work. Okay. There's an issue called poor compliance. Poor compliance essentially means that you follow your own inclinations, right? And we do understand that even in our clinics, right? If you don't follow it, it's not that we're going to cuss you out. We will listen to you, and we'll talk, and we say, why is it that you thought that you could do this? And we will tell you, no, you can't. And so we'll put you back on that path. And we've had some little struggles. Sometimes it's almost a literal fight with patients, but we tell them not to test the waters out. Because there's still a group of persons out there who think, yes, that you may be HIV positive, but it's not time to start the medications. Not too long ago, the actual recommendation now from the WHO is that once you are diagnosed, whether you have symptoms or not, right away you should start on your antiretroviral therapy. Back then, what they used to do, because the medications were still being developed, the medications were not being fully understood, and the side effect profiles were pretty significant. They used to say, don't start people on the medication unless you have to. So that CD4 and viral load that we used to talk about, they would see you periodically from time to time, and once the CD4 count went to less than 200, we would say, all right, we need to start you on medication. When they did that, a significant amount of persons did not make it. All right. So, and the problem, the misunderstanding then was the fact, and it's quite simple. You cannot wait until the house is halfway burnt to then try and salvage it. Yes. You may get some of the fire out, and then the out. So what is recommended now is that once you start, you don't allow the virus to cripple your immune system, because that's another thing we're seeing. The disease once you get to suppression level, the disease is not going to progress. But if something was starting from before, even though your immune system has recovered, you can still get something that you had been suppressed back then. So we still see, sometimes we see some of these lymphomas or brain cancer in these HIV patients. Sometimes we see these little colon cancers and stuff in these HIV patients who are now suppressed, only because the immune system had been crippled at a point. And we don't think it actually fully recovers in those cases. So what you do, you don't give the immune system a chance to be crippled, and then you build it back up. So you should be started on medications. The medications are not going to kill you. That is why we're monitoring you there from day one.
Okay. All right. So I've said a lot about medication. What are some of the names of these medications, or how do they work? And I said before, in simple layman term, not in any in detail, but medical knowledge.
So you're gonna get me into trouble there, right? What we need to know. So the names are pretty complex, right? You have things like tenofovir, lamivudine, dolutegravir, ritonavir, nevirapine, a whole lot of them, right? They come from different classes, right? Which is why we call them combination antiretrovirals. So to draw an example, we have what is known as TLD. TLD is 3 medications in one: tenofovir, lamivudine, and dolutegravir. They have combined them in the right proportion into a nice little small tablet. Patients say that they're very big. And that medication is designed to approach the virus from different levels in terms of its life cycle. So that, yes, you may be infected with the virus. Now, when the virus wants to multiply and it needs a particular substrate, one of those medications will stop the virus from getting that getting that substrate. And once that substrate is not available, the virus cannot multiply. And that is how it keeps things under control. So as we've said, we have not gotten to that point in modern medicine yet when we can eliminate the virus from the body. But what we have conquered so far, and we've come a long way, is keeping the virus under control. So let us say two viral particles entered the body. Their job is to have as much viral babies as possible. Thousands and thousands, so they can take over your body. The medication basically says, all right, I can't get rid of you, but I can stop you from having viral babies. And that is what we keep on telling persons. So it's not like a toothache. When you're feeling sick, or your teeth or your tooth is hurting you, or you draw off a 2 Panadol or something, and then you feel better, and then you stop. This is medication. Unfortunately, since we can't rid the virus out of the body, we have to keep the medication on board so that the virus stays locked away. And once it's locked away, you are good.
All right. So I know that like technology changes rapidly, right? And like certain illnesses, disease, even recently COVID-19, they developed vaccine. So I don't know if I'm going to put you on the spot, but is there what's the latest with HIV in terms of, is there any trying to develop any vaccine or any new medications that can potentially cure the illness?
All right, no. There is still research going on as far as HIV is concerned, right? But that whole family of little retroviruses there, as I said, they are very much ahead of us in terms of evading the immune system. So vaccines tend to work on a particular thing, right? So if a vaccine was targeting a virus because it had a red coat, the virus knows to change its coat maybe to an orange coat. So that when you get infected, and when something occurs now and the vaccine is expecting to see a red coat, you're seeing an orange coat, it wouldn't be effective. So that is one of the reasons why we don't have that. What we do have now, and yes, sometimes you may have conspiracy people who are saying, yes, there is a cure, but them don't want anybody to find out what. I have no evidence for that, and I don't see why you would want to not be putting a cure out there. What we do have is improvements every day in terms of the medication and the ease of taking them. For right now, you can get to your suppressed state, with your oral medications. I know you have medications coming out of the states now where you can actually get an injection.
Okay.
Like once, I think for now it's like once a month, once every 2 months right now. So you don't have to take. So once you just get that medication, you're basically good to go.
Okay.
Are we going to progress to a point where maybe you need it once a year or not? Perhaps, because there are research going on every day as we speak, because somebody wants to get to that point where they can conquer that, whether for profit or for gain or just for popularity. Research is constantly going on.
Okay. All right. So at this point, I think we have covered most aspect of HIV and management. All right, HIV/AIDS. All right, but I just want to give you like a couple of minutes to say one final word for the viewers or for persons that are living with HIV/AIDS, as in what you have observed so far in the years you have been managing these patients who have better outcome, who have poor outcome. What are some of the things that they can do or should do, and also to the general public to decrease stigma on HIV, because at this point we know that we can't just catch HIV from just touching someone or sharing utensils or looking at them or working with them. So the stigma at this point should actually be less.
Yeah, we
based
know
on
that.
current knowledge that we have. So it's still unbelievable how the stigma is so high at this age. But
Yeah,
your turn, Dr. Chad. One final word for the viewers before we go.
All right, so viewers, if you're joining us, we just like to thank you. You're doing a good thing there. I know HIV is real. It has been around for some time and probably will be with us for a little longer as well. What we can tell you is, because we have gained so much knowledge over the years, HIV is not killing persons anymore. When we do see a few persons who would have succumbed, it's usually 1 out of 2 cases. It's either there were persons who did not even know that they were ill, or if it's an established person who have been HIV positive for years, is that person has been non-compliant for whatever reason. All right, and so those are the persons who would succumb. So right now there are persons, you see them on the street, you don't even know, who are living with HIV and they're taking their medications and they're just like everyone else. One of the problems that we have now is this whole thing called stigma and discrimination. We cannot afford to be looking down on people or to be gossiping about it. If somebody has acquired something, yes, you be empathetic, be happy that it's not you. But then that person also needs support. Support does not mean that you talk about it. You go to patient A, you go to this person, you go to this friend, and then you say, hey, oh, you know, who have this thing and who have... That does not help at all. If you have that relationship with that person, first of all, you mind your own business. All right? If that person reaches out to you or whatever, and you have that kind of relationship with the person, you can say, you know, I'm here for you. Right? You just tell me whatever that needs to be there. If you want to talk, you can do that. So if you know somebody who is like that, or you yourself may have been told that you have it, if you're in denial, you can, you may invest in a little. You go to a nearby pharmacy and you can ask them if they have these little private kits, and you can do it in the privacy of your home just to confirm. If it is confirmed, then you need to seek treatment right away, regardless of how well you are doing. In our system, unfortunately, the medication is not just over the counter. It cannot be like that because it's complicated and you have to be monitored. The system that I work in, and I cannot really call the name because I'm not there in that capacity, I'm here personally as a physician there. We have a multidisciplinary team like we've spoken about. We tend to cover persons who are in that particular region, but we also have people in our clinic that are coming from distant parishes. And you're saying, okay, why are they coming from that far? We facilitate that because the whole stigma is real. And let us say you were diagnosed, let us say in a little community in Clarendon, and the provider facility is there, and you have a cousin or somebody going there. We don't want you to sit back home and not get treatment. If you feel comfortable coming to Kingston, anywhere the facility is offered, we invite you to go there, and then you get your treatment. All right, and your follow up, and we treat you with the same respect, and you just explain to us this is what is happening. right? Yes, we will try and get information because we know from time to time you're going to need some encouragement, right? So there's no need for it to be there in the population on a whole. We just need you kind of read up on what HIV is and what it is not. People need support, they need love, and they need encouragement. So if you have it, just go to your doctor. Everything is private. They'll tell you how you're going to be approached. In terms of currently now, there are some doctors who you may be able to acquire the treatment. You may be able to get the medication from them privately, but in terms of monitoring, I think there are only certain facilities that are available to do that. Because I think the ministry would basically need to also keep these things under control, not to track you, but to see what is happening. So your CD4 viral load count will have to be monitored. So it's not every physician may have that ability to do that. But I can say from an island perspective, we have this. We have a full set of persons who are there to help, but we cannot help if you don't avail yourself to those facilities. All right. So on the whole, Jamaica. We need to work on this. It's not just a Jamaican problem, I should say it's a global problem as a matter of fact. Discrimination, it's a very bad thing. And we need to get HIV down to this point where you can be on a bus and you say, I'm HIV positive. It's the same that you can say I had a flu or a cold or something and then nobody comes down and you like that. Because it can affect anyone at any time. Good people, bad people, if there is such a thing as bad persons. So we encourage you to get on board and be sensible about it.
All right, thank you, Dr. Challenger. Well said. And finally, viewers, thanks very much for the support over the couple months that we have this program. And remember to help support this channel, feel free to share, like, subscribe, and leave a comment on this video. Until next time, stay tuned for more informative medical content. And once more, Dr. Challenger, very happy that you took time out of your busy schedule to come and share your knowledge with the population and the world about HIV/AIDS management, and I hope they are beneficial and you should actually continue to keep up the good work.
Be sure to subscribe for more informative contents on life, sickness, and death.